Welcome to the Teaching Value in Healthcare Learning Network. Come join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institutions. I'm September Wallingford, the Director of Operations for Cost of Care, and I'll be moderating today's webinar. We're excited to be joined by Sentil Rajasekaran, who currently serves as the Assistant Dean for Academic Affairs at Eastern Virginia Medical School and leads the Care Forward curriculum reform, and Lauren Mazzurco, who is an Assistant Professor of Medicine and the Director of Case-Based Learning at Eastern Virginia Medical School. Sentil is a PI and Lauren a co-PI on the AMA Accelerating Change in Education grant. Today, Sentil and Lauren will be discussing their teaching innovation, high-value and person-centered care taught through virtual families. Thank you both so much for joining us today.
Thanks for having us.
Thanks for having us.
Yes. So I'd love to start out by having you tell us about your new curriculum, how it came about and why virtual families.
At Eastern Virginia Medical School, prior to last year, we had a traditional discipline-based curriculum, meaning the students will have anatomy, physiology, pharmacology in blocks, and then at the end of second year, they will take the USMLE Step 1 and move on to the clinical years, then graduate. So we realized that we are behind many institutions that have moved towards more innovative curricula. And when we realized that there is a need for change and the administration and the faculty committed to change, we wanted to take it to the next level and see what more we can do in terms of comprehensive change. And so that's how the new curriculum, Care Forward curriculum came to be in place, which is an multi-organ systems based curriculum. And when we decided to use clinical cases, we wanted that to mimic real-world interactions of physicians and patients. So we tried to look at how patients present and what matters to them the most. And we know that patients come multiple times with the same ailments or new ailments to the physician's office. And the comprehensive care needs to address just not the medical condition, but also conditions or circumstances that are beyond the clinic walls, so to speak. And so instead of using isolated cases, we wanted to use cases that the students will see in a longitudinal fashion. And to add to that, and Lauren will elaborate that on further, we also wanted to provide some dynamics between the person who is ill and also the caregivers and in the environment where the person is living. And so that's where the virtual family came up.
Great.
You want to fill in?
And, one of our positions at Cost of Care is that various members of the interprofessional team, nurses, pharmacists, social workers, are essential partners in creating and maintaining high-value healthcare. So can you tell us about who contributed to your curriculum, what interprofessional team members contributed, and how do you help your students better understand the roles and responsibilities of other members of the team?
That's an very important aspect of this virtual family character approach to case-based learning that we have here at Eastern Virginia Medical School. Within our curriculum development team, we have clinicians, faculty from the foundational sciences such as pathology, physiology, biochemistry, anatomy, and histology. We have instructional designers, our librarian, among others, including student representation to help guide this curriculum development. And with the implementation of this virtual family approach, we've engaged numerous Eastern Virginia Medical School faculty and community partners with whom we're working to try to help deliver a comprehensive approach to person-centered care in the context of these virtual family cases. So what does this mean? Because the cases are longitudinal over time, and we have thoughtfully written them to be set in various care settings: inpatient hospital, emergency department, skilled nursing facility, community outpatient offices. We have this ability to introduce various aspects of the care over time, which therefore provides opportunities for the students and learners to engage and recognize the appropriate team members who can make a difference in this patient's care. This may include physical occupational therapy, mental health professionals, pharmacists, social workers, access to community resources in which to engage with the patient and family in a way that's meaningful, because we recognize that the illness experience is not an individual one. It affects significantly beyond that, the family, the community, and all of those aspects. Once we make a decision and have a process for developing the idea of what the focus of the particular case will be around, whether it's high-value, cost-conscious care, care of the elderly, focusing on the impact of multiple chronic conditions, then we engage with appropriate team members to help be present and facilitate the discussion in the small groups with the learners, to be the expert in the room, to help guide those discussions. And in a meaningful way, ask the learners in a self-directed small group discussion to identify which appropriate team members would best help care for the patient and the family.
It's incredibly important. So say I'm a student, can you kind of walk me through how this works?
So the students have engaged with these virtual family cases in several formats over the course of their first year. From a cognitive load standpoint, trying to engage them in a way that introduces many of these concepts without overwhelming the fact that they are learning about foundational and basic sciences, the foundations of medicine. And so they've engaged with these cases both in a paper format and then in a more interactive format along the way, and then come together in small groups in a large group setting to interact with the cases, really develop an understanding of the basic science concepts that are at play, and then how those basic science concepts expand out or zoom out into the patient context, the family context. And that may be through asking them to identify community resources or engage in discussion and debate about what factors are at play that are affecting the health outcome of this individual and their family in that setting.
And how are you creating these cases and these different members of the family, of the virtual family?
That's something we, so we have 5 virtual families now, and they're nothing fancy. They're just, pictures of people who all belong to one family. Okay, they're all really well-developed, professionally developed 3D pictures. And these families represent diversity in our local Hampton Roads community in Eastern Virginia. And we intentionally chose various age groups, all the way from geriatrics to pediatrics, and also wanted to represent issues like different sexual orientation within a family, so that the students see a mix of many things. And also we have an interracial family as well. And so those are the thought processes that happen in the design of the family. And then Dr. Mazzurco, as the director for case-based learning, looks at the whole spectrum of where these cases fit, which age group is appropriate for them, and then she assigns those clinical conditions. And as Dr. Mazzurco is saying, we have a team in place which meets once a week to plan ahead what cases are being used and what are the concepts that can be discussed as a part of this clinical case.
I would also add that the conditions that we've chosen correlate with what the learning objectives are for the week within each of the multi-system modules. Those diagnoses and conditions were identified based on CMS data, most common reasons for emergency department visits, outpatient primary care office visits, and many of the chronic conditions that are overall affecting the cost of care longitudinally in our country.
Yeah, and you bring up the cost of care, and you've talked about how, an illness can affect not just that person, but members of the family, members of the community. So, how are you incorporating value into your cases, which can be a challenge?
We've tried in various ways to incorporate the idea of value. So value has many different meanings, including financial. And so trying to think about not only costs of tests and intervention financially, but costs of tests and interventions, location of care, based on patient-identified goals, based on what values and preferences are about care, and how that may affect their overall personhood and the context of the family. We, with each case, introduce the idea of what type of insurance or lack thereof that an individual and family might have. We also identify things like zip code or neighborhood where they live to identify other aspects in that way. With the financial aspect too, thinking about financial implications of over or under ordering of tests, imaging studies, things like that.
And in pretty much week one, actually, of a medical school, students learn about the different types of insurances and how healthcare is paid for. So starting all the way from there, then the students learn about so when we write a case that's already in there that the patient has insurance X. So then the student should go and do some additional homework on what that insurance pays and what it doesn't pay. And so that's one thing. Another one also we do pretty much in the fourth week of our curriculum is introduce them to choosing wisely.
Mm-hmm.
And so that's something our students get their hands on very early on to see what are the evidence-based resources that they have to cut down on tests. And in the introduction, you mentioned about addressing overuse of healthcare system, right? That's something we talk about in the context of choosing wisely very early on. So those are some of the ways by which we are trying to address value.
Yeah, and that's incredible to be introducing medical students to such a valuable resource like choosing wisely from the beginning. So that's incredible. And your curriculum sounds amazing, and I'd love to hear more about what were some of your goals or some of the outcomes that you envisioned when you were developing this curriculum.
I think that as we consider the aging population and the multiple chronic conditions are becoming more prevalent, these two things, among others, are placing increasing demands on medical and social services, driving escalation of cost and utilization. Simultaneously, we're expecting our students to be change agents and change and improve the quality of healthcare delivery. And so much of what we considered in the development of this curriculum is that social determinants of health often impact health outcomes more so than medical care at times. However, physicians in many cases, in many generations, are not equipped either to recognize or even screen for or know what to do with identified social determinants of health that may be affecting health or health outcomes. So we really took this into consideration. And so by embedding the socioeconomic facilitators and barriers within this family context, we introduce students early on, so it almost becomes a subconscious thought process to identify patient and family challenges in this journey, rather than teaching in a solely disease-centered instruction format, which often doesn't consider or may have limited consideration of patient context. By doing this, the expectation is that we will be graduating more stewards of high-value, person-centered care that takes into account patient and family identified goals, rather than this being an afterthought that's layered on once they reach clerkship or even later in some cases. So that was a big goal for us, to try to incorporate these ideas earlier and more seamlessly rather than being an afterthought.
In addition to what Lauren was saying, in the third year, our students are, maybe this is common to many medical schools, they're active part of the care team. So we want our students to contribute something to the team as opposed to being just to the receiving end of knowledge and skills. And as Lauren was mentioning, we do see, and this is also could be in many other medical schools, physicians are also not very comfortable in seeking this information or dealing with information about social determinants of health. Whereas if we do a good job in educating them in the first 2 years about social determinants of health and what to do with it, then we believe that our students can be better contributors to the health outcomes in being a part of a care team. And hopefully they will also be better residents and probably carry this on when they become physicians. And you asked about some early data. So it's only 40 weeks of a curriculum that we've completed. I can share some, and Lauren can continue about more outcomes. We did a comprehensive evaluation of our curriculum at the end of first year, and also we've been evaluating this model every week pretty much. We have focus groups every week where they talk about their experiences for that week. And consistently, students have thoroughly enjoyed this. And that was one of our goals in the whole curriculum reform, which is to inculcate a love of learning, a joy of learning. And so this aspect, at least the students, because it's low stake, pretty much no assessment, they really love and thoroughly enjoy interacting with these cases and learning more about it. I was just sharing with Lauren before this webinar that when we asked what was the strengths of this model, the students were able to state that they learned more about social determinants of health. The very fact that they're able to state social determinants of health at the end of 30, 40 weeks of medical school is really a thrill to us. You want to talk about other outcomes that you mentioned?
Sure. So some of the other things that we looked at and asked them, we had a very robust response to the survey evaluation that we asked them to complete. More than 60% of them agreed that working through the cases was worthwhile in not only applying foundational basic science concepts, but introducing and acknowledging and working through the social determinants of health, acknowledging and recognizing health inequity, as well as other various outcomes that can help determine health outcomes. They also really latched on to the ideas that patient-identified goals drive shared decision-making, which as a first-year medical student was very impressive to us. In talking with many of our small group facilitator faculty who facilitate in our clinical skills programs, they've identified that students time and time again are bringing up issues, are bringing up discussions about social determinants of health or other family contextual related factors, even in the standardized patient encounters that they've not heard or had heard limited numbers of students addressing in the past before the introduction of this new curriculum. And so that to us is very exciting after 30, 40 weeks of our first year curriculum.
Yeah, and it seems incredibly impressive in how well you've been able to engage your students, because getting students to, shift their way of thinking to this value-based way of thinking is a huge culture change, and I'm sure that it comes with its challenges. So can you talk about some of the challenges that you experienced and how you overcame those?
There are quite a few challenges, I wouldn't say, and Lauren can continue on for 3 hours, maybe the challenges alone. So one of the biggest challenge for us was getting a face time, and that continues to be a challenge to some extent because of the way the traditional medical school is set up. In the first 2 years, they learn about foundational sciences and how that applies to clinical sciences, USMLE Step 1 being a big benchmark for them, and how gateway for them to get into residence and whatnot. So our faculty are really passionate about making sure that our students are well educated about everything that they need to know to do really well in the USMLE Step 1. So getting face time for us to introduce these concepts that are relatively less or non-existent in the USMLE Step 1 is a challenge for us, and we are working through that. It's not that the faculty don't believe that this is important, it's just that they want to make sure that they do good justice to their preparation and readiness for the residency. So anyway, bottom line, face time in the curriculum is a challenge, and we continue to work, negotiate. Lots of negotiation that happens, give and take, where we let go of some things that we're really passionate about. So that's how we are continuing to overcome that challenge. The second one is clinical faculty time and resources, which I'm sure every single one of them listening to this podcast will relate to. That continues to be a challenge, but our administration has been kind enough to find some golden pots of money that can, fund some part-time positions or, things like those, and Lauren with us for that reason, that we're able to find some funding for that. Getting the AMA grant was a big plus, helping us with some resources there. So that to me is the biggest challenge, and some faculty development issues as well, because our faculty are not too comfortable in our absence. Lauren goes to pretty much every week talking about these. And so that continues to be a challenge for us. I'm going to add some more challenges.
I think the faculty development piece and developing consistent language across the curriculum has been one of the big things that we've been working on, not only among the clinical faculty having similar or the same language, non-patient blaming language, using appropriate terminology that's consistent with the literature and evidence base, but also interacting with our basic and foundational sciences faculty to allow them to feel more comfortable engaging in some of these discussions where maybe they wouldn't have before. I think that's been one of the big challenges, been an opportunity, and our faculty have really embraced that along the way, I would say. Really getting the basic foundational sciences faculty and the clinical faculty around the table together and engage in the development and the robustness of these cases has been a huge opportunity, I think, and that has just blossomed, I think, here at UBMS.
And you talked a little bit about administration, and just out of curiosity, how often, I know your program's only been 40 weeks, but how often are you collecting data and sharing that data with administration and leadership so that you can, get more faculty or, get more face time? What's the process there?
So we do, every week we have two forms of collecting data. One is through live focus groups. So we meet with the student elected representatives who have a list of questions. We have standard set of 6 questions that goes out through the students share that through their Facebook accounts, and then the students submit that, and then these class reps go through that and then bring all that information to the focus group meeting. So every week we meet for an hour over lunch. And then in addition, we also have an anonymous forum for the students to share their concerns and thoughts about how that week went. And so that's one way of data collection. The other way is at the end of every organ system module, the students complete a comprehensive set of standard questions. And they're also open-ended questions on strengths and weaknesses. So that's the second data point. The third one, which we did this time because it was the first year, was do this comprehensive survey about how this virtual family performed and how certain components of our curriculum performed. So between all those, we've been able to collect data and share with the administration. And that's how we continue to get more and more support from the administration, actually. I was sharing with Lauren about the new positions that are being created to help us with some more mundane tasks that we were doing. So now we can free up that time and focus on more higher order things, so to speak.
And just as we finish up, I think our viewers and listeners would love to hear any advice you have for those who are looking to create a curriculum similar to yours.
I would say planning ahead, acknowledging that things will take longer than you expect. There are a lot of moving parts to this curriculum, and so frequent meetings, frequent face-to-face meetings to hash out details and think about who the key players might be, so you can engage those folks really early on, especially our community partners who are very busy in their own work as well. I think would be the biggest advice that I would have for folks.
Yeah. Mine would be don't underestimate the students. They are really up for a challenge. Really, we were amazed by the kinds of solutions they brought to the table. And so I'm sure all medical schools are so proud about the students they have and really believe in their abilities to be change agents. But always continue to believe in that and not underestimate the power of students and the ability of them to really be a part of the solution would be my biggest advice. And in terms of logistic boots on ground, what I would say is the model that we use, the power is in the utility of our model, and not really about how the cases look or how the faces look. Really, it's in the utility. You can go as low key as just putting circles and names, or go as big as a talking head in the computer. So depending upon what you want to do. So resources need not be a restriction for deciding at any scale. You can do it at any scale that you want, really.
Great. Well, I want to thank you both again for joining us today and sharing your new curriculum, your innovative curriculum. And thank you everyone who's viewing and listening, and we hope that you join us for next month's webinar. Thank you.
Thank you for the opportunity.